continues to the current day. We occupied for nearly 20 years in the early part of the 20th century. Again, these are things I just like to talk about, and especially with students, since we're all since we get to be at school. And then, of course, the dictatorship, which ended only recently. Unfortunately, the former dictator is back in the country, and there's some tough feelings about that on all sides. The U.S. has stayed close to Haiti, not always in the best of ways. And so Partners in Health has developed into this thing it's become, where I hope it's a place of inspiration and hopefully challenge to you all who are studying and thinking about careers in health and hopefully reaching the rest of the globe. This is where Partners in Health started because of local leadership, an Episcopal priest who was there from the 70s in the middle of nowhere in a rural, isolated, and very stressed part of the country that had been deforested and devoid of much infrastructure. Paul found this local guy who is still critical to the working of the operation. So a partnership that's now pushing on 30 years old, with Partners in Health 25 years in this region. And so starting from a place where deforestation, poor infrastructure, lack of roads, lack of water, hunger, basic infectious disease, these kind of things. These are pictures more recent from a flood that happened in 2008 because of the deforestation, not because Haiti's in a different way than the rest of the Caribbean, but just more vulnerable because of the environment. Food insecurity, hunger, poor nutrition are really the basics we're starting from before we even talk about health concerns. Things like this, a difficult house with no ventilation and no roof to keep the water out, and certainly a few people living under those conditions. Again, poor nutrition. Simple to treat things like tuberculosis were rampant in Haiti, in this region, when Partners in Health started so many years ago. And a lot of what we've built has been around delivering on things like TB and then working to change the conditions that made that a problem. So tuberculosis, just for a little digression since I'm a doctor and already talked a little history. Tuberculosis is one of the oldest known diseases of human beings. Egyptian mummies have been found with TB, and it's something that is worldwide. It's not going anywhere very fast, but it's also an entirely treatable disease. In places like Haiti, where there's been little exposure to the more sophisticated second-line drugs, it's very treatable, and for very little money, $20 or $30 per case. But to do that, you need to provide someone antibiotics on a daily basis for, it used to be 6 months, now recommendations are up to 9, but so day after day for 6 months. The antibiotics are pretty simple. The diagnosis and skills for treatment are not terribly complicated, but getting to someone day after day after day without error for 6 months or 9 months is a big deal. And that's really where the infrastructure that Partners in Health has become was built, and I'll talk about that kind of specifically because it may be, in fact, the most important thing that we're doing, touching on politics and development and the rest of these things, trying to deliver on chronic disease and helping people get well in ways that are not novel. Community health work and delivering care in this way is something that's been done for ages in every part of the world, but trying to do it well is something we've been up to for sure. But then I think the next big step, and what I'll talk about in a second, is to respect kind of why people get sick and to respect where these illnesses come from, not in terms of the microbe and the droplets and someone who's coughing or prevention, lack of prevention measures, but to understand that TB is a disease of social stress. So people who are underweight have a much higher risk of becoming sick with tuberculosis and infected. Crowding in small houses with poor ventilation increases the risk for exposure and getting sick. Distance from clinics and isolation from medical care, and going sort of on and on. To work on those things requires a project that's a lot broader than a clinic or a hospital. TB, again, I promised, maybe the last TB digression. Tuberculosis in this country started to decline precipitously in the 1920s and continued to slide in a pretty straight fashion. The first antibiotics weren't discovered until the late 1940s. So it's a disease that really can be and was controlled in a place like this where nutrition got better, sanitation got better, housing got better. In a place like Haiti, unfortunately, those problems are often not solved, especially for the poorest people. And so Partners in Health, in addition to trying to provide good quality, precise, and well-delivered medical care in these settings, which are tough on their own, we've also been working from the beginning on housing and water, nutrition, agriculture, education very prominently. And I put this up just to reiterate the point that where I'm coming from and where I've been taught to come from, both from the Haitians who've been my colleagues for a decade and a half, but also Paul and the rest of our team at Partners in Health, is to work from a tradition that gets called social medicine. Is that a name or a term that's familiar? It's a good one to hold on to, at least for me it has, and as an orientation. It's not a technical field, but it allows anthropology, it allows engineering and hydrology and all these other things to come in respect that disease and sickness is always inflected by social forces. And in some cases, that's the entire point. So my risk of getting sick with TB is reasonably high because I'm in touch with people who have TB all the time, but I'm not going to get sick because I'm reasonably nourished. I have doctors that I can see very easily. If I needed medicines, they would come quite quickly, and I'm mobile, I can get around. Other things like the cholera epidemic that's happening now is purely a question of infrastructure. It's a 19th century water and sanitation question. It was introduced by international politics and a peacekeeping mission that's not entirely well focused, but it's both hopeful, I think, as people thinking about global health, even the physician side, the treating side, but also a bit challenging to respect that most of what I know how to do and what I can give is not going to affect the bottom line of these social forces. And even on the medical side, we have good medicines for germs. Can't do a thing about genetics. Physical environments, we can change those, but very slowly. And metabolism, yeah, we can change a little bit of that with, keeping exercise and things we do for, say, diabetes. Age, we're not going to change that. So even on the medical side, there's some real limits. So I think working on this social side is just deeply important. And then in a two words to push it back to the human rights context, and this is maybe something for questions, from Haiti again, beginning under an illegal government during a coup period some years ago, I began doing human rights work and now have done some scholarship around health and human rights. And even this number of years in, through that kind of work and collaboration, I'm not always sure it's the best tool to use to create change, but in many ways it can be. It certainly is something that most folks agree on, but putting teeth into it is a difficult issue. One way to perhaps connect the dots from what I've been talking about as social forces of social medicine in the respect that social pressure causes illness or at least makes illness worse. The concept of structural violence, of structures that are violent to people, that are stressful to the human body, to communities, etc., is, I think, helpful in connecting dots from conditions over to the rights that are